Good afternoon, everyone. Welcome to this ESID Grand Round webinar. I also welcome you on behalf of Andrew Kennery and also on behalf of Mirjam. Today we have as topic XLA, X-linked agammaglobulinemia. In fact, that's the first genetically identified immune deficiency, but we still have many questions unaddressed. So therefore, I think it's really important that we have this ESID Grand Round. For today, we have 3 topics selected, and that's on the next slide. So what we will talk about today, that's about what the current long-term outcomes are for patients with XLA. That's a topic that Andrew Kennery will address. And it's important to understand the rationale for early diagnosis of XLA. And then we also like to inform you about the first results and also the efforts for the Stop XLA project. So the program will be as follows. I will give a short introduction, and then we have a movie of 2 brothers with XLA, one with an early diagnosis and one with a late diagnosis. Then the talk of Andy Kennery, then we'll introduce the project, and then Marge will present the first results. And afterwards, I hope we will have an interesting discussion. So I will start not with X-linked agammaglobulinemia XLA screening, but I will start with talking about SCID screening, because I think without screening for SCID, there would not have been an option for screening for XLA. This slide indicates how many countries already implemented newborn screening for SCID, and there are many countries still doing pilots or starting pilots, or decision is pending. SCID screening is based on quantification of TRECs as a measure for T cells. And from SCID screening to XLA screening, it's really a small technical step, because it's only adding 2 primers and a probe in the same assay, and then you can identify whether B cells are present or not based on CRECs. However, doing a test is something else than doing newborn screening, because if we go to the next slide, we see that you can do a lot of things with TRECs and CRECs in combination. It is also illustrated by this slide that already in the past 2 years, there were 26 papers published on these results. So technically it's possible, but it's done already a lot. But still the question whether or not screening for XLA is really a good idea, also in the light of the Wilson and Younger criteria. Because if you go to the next slide, then you can see we still have a question, and it's also a matter from which direction you look at it. Some people say yes, there is still a late diagnosis for hypogammaglobulinemia with consequent lung disease, which gets worse even when on ID replacement therapy. But from the other end, you can also say no, because there is no evidence to show that CREC screening saves lives, decreases morbidity, and is cost effective. So I think this is the topic of this Grand Round webinar, and we are happy to discuss this. First, I will have some technical suggestions. If you have questions you would like to address to the panelists, please do them in the Q&A. If you have more technical questions, you can do that in the chat, and then ESID will take care that the technical problems are solved. So this is the technical part. Before we go to the first item, that is the video, the film of the XLA brothers, I have a question to you. And that is the first question. CREC newborn screening for XLA. What do you think about it? Do you think, yes, that's a good idea? No, that's not a good idea. Or maybe, I'm not sure. Or no, no opinion. So please, may I have your votes? So the first poll said 63% said yes, 4% no, and 31% maybe, I'm not sure, and only 1% that does not have opinion right now. Okay, thank you. I can tell you that we come back with the same question at the end of the webinar, and then we can see whether the opinions has been changed. So for now, I would like to ask ESID to move on to start a video of the two brothers.
Ik heb geluk gehad. Maar mijn broer Bas niet. Bas was als kind ernstig ziek, maar de dokters die wisten niet wat het was. Hij had longontstekingen, darmontstekingen, oorontstekingen. En pas toen ik geboren werd en ik dezelfde symptomen had, bedachten ze dat het misschien iets erfelijks kon zijn. En zo kwamen ze erachter dat wij de zeldzame ziekte XLA hadden. En toen konden ze de juiste behandeling beginnen, zowel bij mij als bij Bas. Alleen doordat het bij Bas pas 5 jaar later werd ontdekt, heeft hij enorme schade aan zijn lichaam opgelopen waar hij nog steeds vandaag de dag mee kampt. Hey Bas, hoe is het jongen?
Ja, gaat wel. Een beetje matig hoor.
Wat dan?
Een weerstand is natuurlijk matig en met allemaal longschade van vroeger en zo vind ik het toch niet veilig om weer voor de klas te staan.
Het voelt soms een beetje oneerlijk dat jij daar zo thuis zit en ik wel gewoon redelijk vrij ben om te doen en te laten wat ik wil.
Nee, ja, weet je, voor mijn 5e had ik al 3 keer longontsteking gehad.
Ja.
En omdat ze niet wisten dat ik XLA had, en daar had ik al die longschade niet van. En als het nog langer had geduurd, voordat ze dat ontdekt hadden, dan was ik er misschien wel niet meer geweest.
Wat Bas is overkomen hoeft straks hopelijk niet meer. Want in Nederland wordt op dit moment bij alle kinderen de hielprik uitgevoerd. En wat wij met dit onderzoek willen aantonen is dat XLA ook op een betrouwbare en goede manier kan opgespoord worden via de hielprik. Als XLA in de hielprik wordt opgenomen, dan kunnen we ouders en kinderen veel leed besparen. Want we kunnen die diagnose direct stellen na de geboorte, eigenlijk net zoals bij Koen. En dan kunnen we meteen starten met een behandeling.
Daarom is het goed dat we het onderzoek doen naar het opnemen van XLA in de hielprik. Dan voorkom je al die schade aan longen of aan bijholtes waar ik nu mee loop.
Als mijn broer via de hielprik getest was hij nu net zo gezond als ik. Dus geef XLA geen tijd. Stem op ons.
Okay, this movie was taken also during the Corona time, so that's also where the interactions were online. And this was also part of the project that was initiated also between patients and researchers and also 5 clinicians. So this is an illustration of a story of 2 brothers. Now I give the floor to Andy, who will give a presentation of the results obtained in a large UK study.
Thank you very much, Mirjam, and thank you to you and to Siobhan for asking me to be part of this. And it's a great privilege to be part of this. I'm actually going to present data that's been collected mainly by Ben Chinito, who was one of my PhD students and has now just got a consultant job in Sheffield. I think he's actually one of the participants. And I think these are interesting data. I'm not sure what I think at the moment. I think newborn screening generally is a good idea, but I'm not sure we've got it right for XLA just yet. We've actually expanded our study a little bit since these data were collected, and we've got information from patients in Scotland and Northern Ireland as well. But these are just patients, some patients in England and Wales. So, I mean, I don't really need to spend too much time explaining about X-linked A-gamma globulinemia to this audience. We all know that BTK is important for signaling through the B-cell receptor and indeed for development of B cells, and that when there is a mutation in the gene and faulty protein, we have early maturation arrest at the between the pro-B and the pre-B stage. We know what B cells do. They make antibody, but actually they do more than that. They are involved in making different cytokines, which can have downstream effects on other immune cells. They have an important role in regulating dendritic cells, and they're also involved in T lymphocyte co-stimulation. And we know that BTK has a number of other roles other than just the maturation of B cells, and that might be important when we're thinking about some of the problems that we see in patients with X-linked agammaglobulinemia. Current treatment, as you know, starts at diagnosis and is replacement of immunoglobulin, although not replacement of B cells. And that's given either IV or subcutaneously, usually weekly or 2 weekly or 3 weekly, and it can be in a hospital or clinical setting, or indeed it can be at home. And there's maybe conflicting evidence on effectiveness. Of course, the immunoglobulin that we give is almost 100% IgG, and there's very little IgA and IgM. And IgA, of course, is really important for protecting lungs and other mucosal surfaces. So what Ben did was gather clinical information from the notes of patients with XLA in England and Wales, and we also did some quality of life surveys using recognised and validated tools, particularly looking at psychological and emotional well-being, but also specifically looking at the respiratory disease with a respiratory questionnaire. Data on patients was gathered from the UK PIN registry, and in the UK PIN register, when we looked, there were 159 patients registered in the UK, giving a prevalence of 2.4 cases per million of population and a mean incidence of 1 case per 2,000 live births in the UK. The incidence appears to be increasing with time. I'm not sure if that's a real increase or whether we're just better at diagnosing it. At the time that we gathered these data, we had 54 patients recruited from 9 centres. That gave us over 1,000 years of patient follow-up, and about half of the information that we might have wanted was available in total clinically and in terms specifically of immunoglobulin doses and levels. Median age of the cohort at the time of the study was almost 27 years, with a median follow-up of almost 21 years. And the majority of patients were adults rather than children, and predominantly Caucasian. The median age at diagnosis was 2 years, and that possibly is improving over time. But in a number of cases, actually like in the video that we saw, there was a diagnosis based on family history. And if you strip that out, then I'm not sure it's quite so clear that the age at diagnosis is improving over time. So I think that is a question. As I say, there was about 20% of patients screened based on the family history. Interestingly, there were some families where, despite a family history, even symptomatic boys weren't necessarily screened, and there was a delay in diagnosis. Of those that weren't screened, they were presenting with infections, predominantly of the lower respiratory tract. But there were a number of serious infectious diseases, including sepsis, central nervous system infection, joint infection or osteomyelitis, and also tuberculosis. And you can see here the presenting symptoms in the table. Interestingly, once we started treatment, infections were still a problem. Actually, invasive disease was very rare, and that bears out previous studies, but respiratory infections were common. And there were the usual suspects with Streptococcus pneumoniae, Pseudomonas, and Haemophilus. Again, interestingly, there was no significant difference in the incidence of infection, either pre-diagnosis or post-diagnosis. So whilst, as I say, the invasive disease was extremely rare post-diagnosis and post-treatment, there was no difference in the incidence of infection, and that was predominantly respiratory infection. That might be important, because 60% of the cohort had abnormal high-resolution CT scans, of which 44% had proven bronchiectasis. Again, interestingly, a fifth of patients had endoscopy for bowel disease or bowel symptoms. 6% of them had inflammatory bowel disease or inflammatory bowel-like disease, A number of them had chronic diarrhea, and at least 2 patients had persistent norovirus. And in fact, they have both progressed to stem cell transplantation subsequently. One was a child, one was an adult. And there were other comorbidities. 8% had arthritis post-infective. There were a small number of patients with memory disturbance, and at least one of those was linked to CNS echoviral infection, and then deafness, which was usually related to pre-diagnosis meningitis. In terms of disease severity, we could rank it from asymptomatic, mild, moderate, and severe. Severe having end organ damage requiring significant intervention, for instance, lung transplantation. Patients with moderate disease were significantly older than patients with mild disease, but there was no difference in age at diagnosis. In terms of immunoglobulin therapy, there was a 50% split between subcutaneous and IV therapy. Most of the IVIG was, well, it was 50% either way. Most pediatric patients had subcutaneous immunoglobulin. And the lifetime median IgG trough was 9.37 grams per litre. And I think that's important because, you know, that's actually a reasonable trough level. And there was no correlation with the median IgG trough level or with the median lifetime infection incidence. In terms of genetics, null mutations were most common, but there was no difference in presentation, infection incidence, or disease severity that correlated with the type of mutation. Median age of onset of bronchiectasis was 22 years. Now that, of course, is quite tricky because bronchiectasis is a disease that is ultimately diagnosed on a CT scan, and there may well be disease that is occult or not considered that is present before then, but the median age at the onset that we discovered was about 22 years. And importantly, by about 33 years of age, there was a 50% risk of having bronchiectasis. In terms of the IgG trough levels, there was no significant differences in infections with patients who had bronchiectasis or those that didn't. There was no differences in infection incidence pre and post bronchiectasis diagnosis. There was no significant difference in the lifetime median IgG trough levels in those that had bronchiectasis versus those that didn't have bronchiectasis. IgE levels had a trend to be higher after bronchiectasis was diagnosed, although that was not significant. And in their pre-bronchiectasis period, before bronchiectasis was diagnosed, patients had similar IgG trough levels to current healthy patients. In terms of age at diagnosis and follow-up, patients with bronchiectasis were diagnosed with XLA significantly older, perhaps reflecting what we saw in the video, and patients with bronchiectasis are significantly older. Age at diagnosis, asymptomatic screening and respiratory infection incidence did not seem to affect the risk of developing bronchiectasis. And I suppose the unanswered question is whether those patients who are currently young are inevitably going to develop bronchiectasis despite the fact that they're on treatment, or whether the fact that they're on treatment now will prevent the development of bronchiectasis. And I think whilst there are some hints in our data that suggest that maybe the development of bronchiectasis is inevitable, perhaps because the current treatment is actually not completely adequate to prevent the progression of respiratory disease, I think that's not a question that is completely answered. When we looked at lung disease progression, there was no significant difference in the first recorded versus the latest FEV1 scores. It was similar whether or not bronchiectasis was present. Patients who did have bronchiectasis now tended to have lower initial FEV1 scores compared to current healthy patients, but that score was stable over time and wasn't really changing. There were increased respiratory tract infections in patients with lower scores. In terms of quality of life, we didn't really find any issues in pediatrics, both in terms of the self-report and the patient's report. When we look at adult quality of life, patients with bronchiectasis had lower quality of life scores in the physical function, pain, general health, and overall score domain than patients with XLA who didn't have bronchiectasis. This is adults. When we look at the respiratory health questionnaire, the St. George's questionnaire, unsurprisingly, patients who'd got bronchiectasis had significantly worse scores in all domains compared to healthy norms. And there were no differences in respiratory related quality of life compared to bronchiectasis patients with cystic fibrosis. So this is severe disease. Importantly, adults without bronchiectasis had a normal respiratory health related quality of life score. So if we summarize the main findings, I think today mortality in XLA is extremely low, but even on immunoglobulin replacement therapy, with what seem to be reasonable trough levels, patients still experience recurrent respiratory tract infection. And even with today's treatment, lung disease and bronchiectasis remain major comorbidities, with certainly in our cohort an approximately 50% risk of having bronchiectasis by the age of 30, which didn't appear to be related to the immunoglobulin therapy, the infection incidence, or the IgG trough levels. I think the other thing to remember is that there are other manifestations of XLA even on patients who are on immunoglobulin, including particularly gastrointestinal disease, and that can actually be a really particular issue to manage. I'm not sure that we can treat it particularly well. Chronic viral infection or inflammatory bowel disease, and as I say, 2 patients actually underwent stem cell transplant because of chronic bowel infection. One was for a couple of years and one had had it for going on 10 years or so. So I don't think, even on current treatment actually, that XLA is a benign disease. I think there are still significant issues with it. I think you can get enteroviral infection, particularly the CNS. As I say, problems with gastrointestinal disease and chronic infection, inflammatory bowel disease, maybe joint infections. And I think there is this inevitable development of bronchiectasis question. Are patients going to develop it as they get older, even on immunoglobulin replacement, even if we think that they're on adequate doses with adequate trough levels? And that certainly leads to quality of life issues with chest disease. And then the wider questions, it's not even easy, even in Europe or in some parts of Europe, to easily access immunoglobulin. And there's a significant lifetime cost to immunoglobulin treatment, and that can be a problem for resource poor countries, even in Europe today. And of course, it is a blood product, so there is a lifetime risk of giving a blood product, however safe we like to think that might be these days. And so just briefly, data on the patient that we transplanted was a young boy who was actually diagnosed by about the age of 9 months. He developed chickenpox from his sister and was being followed in a centre where there was a very smart paediatrician who noted that he'd got absent immunoglobulin and made the diagnosis very rapidly. He started on immunoglobulin treatment and had reasonable trough levels and was okay for the first 6 years or so, but then developed chronic norovirus infection, so much so that he stopped growing and required parental nutrition, and also that he had very difficult immunoglobulin trough levels despite being on high subcutaneous and intravenous immunoglobulin dosing. And so we took him to transplant, and perhaps unsurprisingly, when he immune reconstituted, he got B cells. He cleared norovirus actually before he got B cells, suggesting that maybe XLA is more of a combined immunodeficiency than perhaps we thought. And as he developed B cells, unsurprisingly, he started to make immunoglobulin. We took him off his replacement. He started to grow and has now almost on the top centile for growth, for weight, and not quite so much for height. He's off his immunoglobulin replacement. He's off all of his medication, and he's made responses to his vaccines. And as we were writing this up, we did a literature search, and he's one of about 16 patients reported who've had transplantation, either with or for XLA, all of whom have survived and most of whom have come off their immunoglobulin. So I think there are a number of unanswered questions in this disease. I think early diagnosis probably is essential, but I'm actually not sure that the current treatment that we've got is adequate to prevent enteroviral mycoplasma infection and certainly inflammatory bowel disease. I wonder whether early diagnosis will actually prevent bronchiectasis, or is it inevitable with the treatment that we're currently giving? And therefore, if we're going to offer newborn screening, do we actually need to rethink our treatment strategy? Because we don't want to diagnose these patients at birth simply to end up with the same sorts of problems that we see in the current cohorts, because the treatment we're offering isn't good enough to present some of the problems. So I'm going to thank particularly Ben, who did the legwork for this study, Mark Pearce, who was a co-investigator and helped with the statistics, our funders, the UK registry, who allowed us access to the data, and then the participating centres and PIs who were involved in the study. So I'm going to leave it there, and I think that we're going to go for questions at the end of the whole session, and I'd be happy to discuss further.
Okay. Thank you very much, Andy, for your wonderful talk, and also giving us more insight in it's not only an issue of diagnosing, but also of treatment, and that as to really advance the field, it's there's really needs to be made next steps also in the way of treatment. If you agree, then we go to the for the questions at the end in the panel discussion. We leave it for then, and also questions can be put in the Q&A. So for now, I would like to introduce the project we are thinking about, and the title we gave to the project is Early Identification of X-linked Agamoglobulinemia via Newborn Screening, Evident Innovation in Patient Care. And in short, don't give XLA the time. So on the next slide, I showed you the project team, how the project actually started off. That was a collaboration between scientists, clinicians, patients, parents of patients, and the patient organization. And it's nice to mention that this initiative, in Dutch it was Geef XLA geen tijd, don't give XLA the time. This initiative was rewarded by the Dutch Society of Medical Sciences for the most inspiring collaboration between patients and scientists. And I think that also indicates the power of doing this work together. And I think when we started at a national level, but in the next slide, we realized already in a short time we cannot do this alone. We really need to do that at an international level via Europe, or maybe even wider than that. So in the next slide I can show you the outline of the project. So we thought the main questions to be addressed was, first, does early diagnosis of XLA result in better patient outcome? And also, I think the study of Andy is really already contributing and answering part of these large part of these questions. And the second part is, what is the most suitable test method for neonatal screening? So the first part, we thought about questionnaires for the patients, but also questionnaires about the parents, what their perspective is on newborn screening. And we would like to do a retrospective study at the international level. And also for this, we collaborate with the ESID and also with the UCID net from the US. And then the technical parts, I already mentioned the KREC assay, which can nicely measure in dried blood spots. But we think there needs to be a second tier, a second test method before referring. And one of the assays, what is a possibility, is epigenetic immune cell counting. And Marcia will also talk about that. And also later on, we also think about sequencing a second tier test before referral. So this together should give us an answer whether early identification of XLA via newborn screening is really an innovation in the patient care. So on the next slide, I show you our funding scheme. First, we had a grant from the Jeffrey Modell Foundation to explore the data that's already there from the via UCITNet and XLA. And we get support from the Dutch Society of Medical Sciences for the entire project. And recently we obtained a grant from Takeda to really give the project the possibility to do it at an international level. So they will typically support really the questionnaire studies and also the clinical studies. So that's also a great opportunity for European centers to participate. And also we also have funding to collect this data, because that's also a big issue always. So now we'll give the floor to Maartje, and she will present the first results on the second part of the project, so the KREC analysis and also the epigenetic immune cell counting.
Yes, thank you, Mirjam. I will share my screen. All right. So as Mirjam just explained, I think she gave a very nice outline of the project. Again, this is the scheme that we are working with. So we have working from left to right, working with the questionnaires, the retrospective analysis of XLA patients, and the test methods. And what I want to do today is discuss with you the first steps that we have already taken in this project and the first results that we have shown, actually. And we're going to work from right to left. So what we're going to do is we're first going to talk a little bit about the most suitable method for neonatal screening for XLA, and then work our way up to the questionnaire study. And also, of course, discuss how other ESID centers can participate in this. So indeed, KREC analysis, we already made some first steps with KREC analysis in the Netherlands.
Maartje, we only see the first slides, so we don't see the presentation mode.
Oh. Just a second. Share. You can see the full screen now, I think.
No. Yes, now we do. Yeah.
Good. So, as I was explaining, indeed, the KREC analysis. This is what we've done already in the Netherlands. What we've done in the Netherlands is we started with this large prospective implementation pilot for newborn screening for SCID. And in that pilot study, we analyzed all newborns from 3 provinces from the Netherlands for SCID. However, simultaneously, we used a multiplex TREC KREC assay from ImmunoIVD, so we could also measure KRECs in an anonymous manner, because we didn't refer these newborns, so we only have the anonymous data. And we analyzed approximately 110,000 newborns, and of that 110,000 newborns, there were 136 newborns who had low KREC levels below the cutoff value. And we used a cutoff value of 6 in our program. So this means that you will have a referral rate of 0.12%, and that is actually very high for any newborn screening program. So this means that it would be associated with not only a high number of referrals, but most of these referrals would have been false positive cases. And from previous studies, we know that any referral is associated with a very high emotional impact for parents, and not only for parents, but also for healthcare systems. It would put a lot of workload on the Down Center referral academical hospitals, for example. So that means that there's probably a need for a second tier. And a second tier test would be a test that you can still perform within a newborn screening laboratory on dry blood spots. And we have actually, looked into different kind of test options that are actually noted here. So first, I will talk a little bit about epigenetic immune cell counting. Epigenetic immune cell counting is a technique that is developed by the company of Immune, and what they have actually developed, or what they are working with, are these unique segments of DNA. You can actually see them on the left side. They are unique segments of DNA that are demethylated for your target cell types. And in our case, our target cell types would, of course, be the B cells. In all other non-target cell types, these segments of DNA would actually be methylated. What happens if you add bisulfite is that your non-methylated cytosine will actually be converted into a uracil. However, in your non-target cell types, these cytosines are actually protected by the methyl group, so no conversion will take place. And you can now develop unique PCR primers for your target cell types, leading to a PCR product, and therefore being able to distinguish them from your non-target cell types, which is actually a very elegant method to measure, for example, B cells, but relative B cell counts in dried blood spots. So this is what we are also seeing here. What we did is first we looked at the correlation between the KREC copies and also your unmethylated BLC copies, so B cell copies. And in blue, you see the newborns with low KRECs, and in black, you see your healthy controls. And you already see that there's actually not that much of a good correlation between the TREC copies and the unmethylated BLC copies. So it's a correlation coefficient of 0.6. But that's actually good, because that means that your epigenetic immune cell counting assay can actually produce different results than your KREC assay and has an additional value as a second-tier test. And this is also actually described here. What you can see on the left side is just your KREC copies measured with qPCR. You can see again the healthy newborns in black, and you can see the newborns with low KRECs in blue. And of course, you see a significant difference between both. And if we're now looking at our relative B cell counts, so our relative B cell counts as a total of your leukocytes, you can see now that there's actually some of the newborns in the group with the low KRECs that have relative B cell counts in the range of the healthy controls. So we analyzed 103 newborns with low KRECs, and 18 of them were in the range of the healthy controls, and therefore would not have been referred if you would use epigenetic immune cell counting as a second-tier test. This is also something we did with an other commercially available KREC assay. So what we did is we used an other assay, just measuring KRECs again and seeing if we could have prevented some of the referrals that we would initially have. So we used the PerkinElmer assay. It's now currently available as the Jonas assay, which is a multiplex also for TREC and KREC and also SMN1. And we again analyzed our newborn cards with the low KREC levels, in this case 110 cards. And you can see already here, if you use the cutoff value of the manufacturer, which is the line in red, you can now see that there were still 16 newborns of 110 newborns that have now normal KREC levels, or indeed KREC levels above cutoff. However, these numbers are not really making that much of a difference. We are actually looking for an option that reduces the number of referrals significantly. So that is why we are actually thinking, is genetics maybe an option to use as a second-tier test in a screening program? At first, if we're looking very strictly at XLA, we thought maybe we can just do BTK gene sequencing, just Sanger sequencing. So this is what we tried. We again used 40 samples of these low KREC samples and also analyzed 4 XLA patients. We isolated the DNA from these bunches, and then we analyzed 19 exons, because the BTK gene is of course 19 exons long. However, what we saw was actually that the overall success rate of the sequencing was quite low, and we needed a lot of optimization steps to clean up, but also developing new primers, addition of adding extra sample, and that led to an overall success rate. So all exons were successfully amplified and sequenced of even lower than 50%. And this is probably due to the DNA being very fragmented because it's isolated from dried blood spots. So BTK analysis probably is not the way to go as a second tier, because it's very time consuming and also has a low overall success rate. So the next step that we want to explore is rapid NGS. So we want to develop, or we have developed, a B-cell panel in collaboration with PerkinElmer, or with Thermo Fisher in this case. And we will be running it on the dried blood spots. And next, well, it's a rapid NGS, which means that the results will be in 24 hours, approximately 48 hours after analysis. So that brings us to the middle part, our multi-center retrospective analysis. And we already done some steps in this study as well, because I think this is one of the most important questions at this point. I think Andy really nicely described it, but does an early diagnosis of XLA actually lead to better health outcomes? I think at this point, we don't have a large-scale study that makes this, well, this hypothesis actually quite hard. So what we need to do is we need to collect clinical parameters such as mortality and also morbidity. And we need to make the comparison between XLA patients with an early, for example, positive family history and a late diagnosis on an international level. So what have we done so far? Again, we have our medical ethical approval at this point to do indeed an international retrospective data collection. We first also had the approval to use the ESID registry data and also the ESID registry data. And we did also a collaboration with Margareta Pak because she has a big Polish cohort of XLA patients as well. However, we of course met some hurdles and some limitations at this point because what we saw in the ESID registry, maybe some of you know it, the level 1 data that is available there was actually insufficient to answer our research question because the available data is very limited. It only states, for example, were there infections, yes or no. It only has a birth year, which makes early or late diagnosis already a bit harder. So we couldn't use the ESID registry data to answer this question. And it was kind of similar for the ESID registry because there was a lot of missing data in this registry. So initially we had approximately 250 patients, but if we excluded all the missing data, we would only include 63 patients. And also there were no uniform applied guidelines for the data entry. So there was a lot of difference in the data sets. We did get to do some first analysis. So we saw that XLA patients with an early diagnosis indeed had less airway infections before diagnosis, but again, there were no differences in after diagnosis. And there were also no data available on mortality. I think this also, again, is kind of similar to the study that Andy already showed. So we're in need of a larger sample size. And we can only do this if we, of course, collaborate on a multinational level, on an international level. So what we did is we developed now a data collection sheet, also instructions for data entry so that there's no confusion about how the data should be entered. And we contacted the ESID Clinical Working Party and discussed that maybe we can work together with the ESID clinical centers to collect this data according to our new data collection file. We created this data file in Castor so that local researchers can just complete it online. And maybe if also patients give permission again, the data that is collected can also be forwarded again into the ESID registry so that it's also helping the ESID forward as well. So that leaves us just with the questionnaire studies. So there's 2 questionnaire studies that we're actually planning. And I think we briefly discussed them already. The first one is the quality of life questionnaire study. And this is because we, of course, are discussing that an early diagnosis for XLA will result in better health outcomes. But health outcomes are not only our clinical parameters. They are also, for example, quality of life. So what we want to do is we want to compare quality of life between the XLA patients with an early diagnosis and also with a late diagnosis. And secondly, we also want to know what parents think. So we want to ask parents of XLA patients, how did you experience the whole diagnostic process of your child? And also, what do you think of an early diagnosis of newborn screening for XLA? So these questionnaires have already been developed. We've discussed them both with patients, also with parents and family members, and also with our Dutch patient organization. And our Dutch Medical Ethical Committee already approved the sending out of the questionnaires. So the first one was actually sent out last week, and we got 1 result so far. So we're still working on it, but I just wanted to show a nice quote that was included there. So this was the patient had a diagnosis at the age of 4 months, which is actually quite early. But the parents stated an early diagnosis would have been welcome indeed. The diagnosis for our child took approximately 3 to 4 weeks. And they said, well, although this period was very stressful and emotional for us, we later found out that this was actually quite fast because these parents have been in contact with other patients and parents as well. So they learned from XLA contacts abroad that in some cases it took more years to make the diagnosis. So in that light, the diagnosis for our child was very rapid and we were very grateful for that. So I think that's a nice quote from our first questionnaire that we got back. So what are we going to do next? First of all, we, of course, are going to contact via the ESID, probably a lot of you to collaborate in this research as well. So we want to ask you if you want to contribute both to our clinical data study as well to a questionnaire study. We've also already discussed it with IPOPI because we want to involve IPOPI while we are translating the questionnaires for local centers, if they can help us also with the fine-tuning of the questionnaires with their local patient organizations as well, just to get a little bit of feedback on the questionnaires. And this first preparation phase, of course, also includes local medical ethical approval. Once the preparation phase is over, we can go into the data collection phase, which means that we will be sending questionnaires that are translated into the language of your country. We will also be sharing our data collection file and also the COSTOR entry file with the instructions as well. Local centers can then directly send it to their patients. Patients can again send it back to the local centers and to the local physicians, and they can forward it back to the LMC, to us for the data analysis. So this is the work plan. Again, very shortly, the preparation phase that we are now in. We are translating the questionnaires into the languages of the participating centers. And then we will also organize an online kickoff meeting for all centers to give a little bit of more information on what's going on. Afterwards, we will start with the patient inclusion, both from the clinical data, but also from the questionnaire study. And finally, we will, of course, start analyzing the data. So finally, how to participate. After this meeting, you will all receive an email with additional information and also the invitation to participate. We can then send you, if you want to participate, a link to COSTOR, so you can include the anonymous clinical data collection, and you can receive a format already for the medical ethical approval. We have one available in English, so we can also help you with this as well. We have then the questionnaires and also the patient-informed consent forms, and after ethical approval, the questionnaire study can start. So if there's any questions, you can, of course, contact me or Mirjam. And if you already know that you want to participate, you can, of course, contact us as well. But more information will also follow via email. So with that, I will give the word back to Mirjam.
Okay. Now, thank you, Maartje, for your presentation, also explaining about the project and sharing with us the first results. Then I would like to open the discussion also with the panelists. We already have some questions in the Q&A, so I will address them. The first question is to Maartje, also related to her presentation. That's a question from Claudia Rita. The question is, are CRECs low in prematurity or other immunological disorders?
Yes, they are low indeed in prematures as well, or in preterm births as well. So it's very much recommended, similar as to newborn screening for SCID, that if you would include newborn screening for XLA, you have an additional either adjusted cutoff value for your preterms, or you would request a second newborn screening card for your preterms after, for example, the gestational age of 37 weeks is reached. And it's also the case, I think, for some other immunodeficiencies as well, or inborn errors of immunity as well. I think there's a very nice publication on it, on which immunodeficiencies has low TRECs, either or CRECs. But for example, in some CVID patients, we've also seen that there's low CRECs. So it's not a specific marker only for XLA, but it's more general in all B-cell deficient patients.
Okay. Thank you. And I have a question for Andy. It's a question from Tanya Mos. The question is, how early after diagnosis in newborn, so diagnosis prenatally due to family history or postnatal screening, do you start with immunoglobulin replacement? And then do you recommend subcutaneous or IVIG in newborns?
I mean, the physiological way really of giving immunoglobulin these days would be subcutaneous, so we would certainly recommend that. In terms of how quickly do you start, you have, of course, got a few weeks if the baby's term. Hopefully, assuming mum's immunoglobulin levels are normal, she should have passed over some IgG across the placenta to the neonate. So you do have a few weeks before starting, but it's going to drop fairly quickly. And so I think you would want to start within the first 6 weeks, probably.
Yeah. And there's a question from Nouvar Marcus Mandelbilt, also for Andy. Do you think we should offer stem cell transplantation for newly diagnosed XLA patients upon diagnosis?
I think this is a really interesting question, and I don't know the answer is the short answer. I think there's a couple of things you could say. If you look historically, when we started transplanting patients with chronic granulomatous disease, we did get some kind of pushback from the community generally, because it was felt that conventional treatment was adequate and that stem cell transplantation was very dangerous. And actually, if you look today, the gold standard treatment, I think, certainly in the Western world for CGD, would be stem cell transplantation. So I think things have changed for that disease. And I guess there's a question mark as to whether XLA is in a similar position, that we've got a conventional treatment. We think it's safe, although clearly there are some potential issues with bloodborne infection, rarely, but not zero. And there's clearly an expense part to that as well. And, you know, that's been really an issue through the pandemic, for instance, when there have been shortages of immunoglobulin. I think we need really good data, to be honest, on what the long-term outcome of early diagnosis with adequate immunoglobulin levels are on patients with XLA. If you want my gut feeling, it's not good enough for two reasons. One is we're not replacing all elements of the immunoglobulin, but only the IgG. And two, that BTK isn't only involved in making antibody, but B cells have other functions and BTK is involved in other cells as well. So I do think this is more of a combined immune deficiency than simply an antibody deficiency. And therefore, it is worth thinking about other potential treatments. I do think that we should consider transplant for some patients. And, you know, the patient who's got persistent viral infection, particularly the pediatric patient, where transplant outcomes are generally very good, I think we should move beyond thinking we should never transplant these patients to thinking, well, maybe we should be offering transplant to some. I think we're a long way from saying that you've got a diagnosis of XLA, therefore that equals transplant. And I think we need good data on what the long-term outcome, knowing what long-term outcome in the modern era. And that's the problem, of course, with registry data, that when you look at the 30-year-olds, they probably weren't getting the treatment that our newborns would get today. Yeah. And the same was true with CGD, that, you know, the old data of not good mortality was showing really historic treatment. And that is one of the issues. But my gut feeling is that actually even today, that simply immunoglobulin replacement isn't going to be good enough.
Yeah.
But I wouldn't yet say that we should be transplanting everybody.
Yeah. And also a question related to your notion that you say it's not pure antibody deficiency, but also maybe other cells involved. And there's a question from Austin Stack and asking any thoughts into the potential cause of bronchiectasis? Is there abnormal macrophage response in the lungs?
I mean, that's possible. But actually, you know, the immunoglobulin that best protects the lungs is IgA, and we don't give that. There was a very interesting study from Alain Fischer's group a few years ago, who looked at the difference between patients with XLA and those with hyper-IgM syndrome. And of course, hyper-IgM syndrome don't have any IgA or IgG because they can't class switch, but they do have IgM. And their infection rates were much less than patients who were completely agammaglobulinemic. So even having IgM, which we tend to think of as being the not quite so good antibody, gives you a definite protective effect compared to nothing at all. And I suspect that the main issue in the lung and possibly in the gut is not having IgA. But I'm sure that there are other cellular components that are important to protection as well.
Now we will move on to the question of Stefan Borte. He did a lot of work in the pioneer work of the TREC and the KREC. He's asking why not lowering the diagnostic cutoff value of KRECs to below 1 copy to reduce the additional burden of second-tier testing, thereby making the screening program more specific for XLA and autosomal recessive agammaglobulinemias. So that's also done in Sweden, Austria, or Swiss other programs. Maartje, could you reflect on that?
Yes, very good question. I'm constantly having the discussion about cutoff values for newborn screening for SCID as well. But what I know, for example, for the assay that we are currently using is that the limit of detection of our qPCR assay is approximately 3.7 copies for KRECs, which means that everything between 0 and 3.7 is actually the same. So I think lowering the cutoff value to 1 is probably not a good idea, because it has a lot of, I think, in the lower limits, a lot of error. And I've also seen some results from XLA patients who didn't have exactly 0 cracks. So we all know that for the most SCID patients, especially the classical SCID patients, they have 0 TRECs. But there's also some results from XLA patients who are, for example, a little bit around 2.6 cracks, and you would miss them if you put your cutoff value that low. And I think you could not do it in a proper manner if your limit of detection is actually not at 1, but a little bit higher than that.
Okay, there's a clinical question from Dr. Sinia. It's true that management of enteroviral encephalitis and colitis seem to be the hardest to treat, to manage and to predict. It's also tough to convince our transplant physicians given the lack of data of XLA transplant, especially in adults with XLA. What are your thoughts about that, Andy? Oh, you're still mute.
Still mute, yeah, sorry. For transplant, I mean, it is difficult. I think, there are increasing data to suggest that the outcome of transplanting adults with primary immunodeficiency is actually pretty good. And it might not be quite so good as pediatrics, but it's certainly at least comparable to transplanting adults with malignancy, if indeed not better. Of course, it depends on how sick the patient is. And that's always the balance when you're thinking about transplant. If you're going to transplant an adult, you need to wait before they need a lung transplant. Sorry, yes, you need to do it before they need a lung transplant. I think, it will, given that the whole area of transplant for XLA is still pretty controversial, even in pediatrics, I think it will come in adults, and it will start in some bigger centres and probably roll out. In terms of treatment of encephalitis, correct. I mean, it's horrible. And that's why I think we need good curative treatments for XLA, not just a little bit of immunoglobulin, because actually we can't really do anything about it. It might depend a little bit on the virus, except that my experience in T-cell deficiencies is you need cells to get rid of these viruses. We know the patients that had norovirus, the adult that was transplanted, was actually written up about, probably 5, 6, 7 years ago, who had, and I can't remember what treatment they'd had actually, but it was to describe how successful it was. And yet they were transplanted last year because it wasn't successful at all. So I think if you've got viral infection and a combined immune deficiency, the pharmacological treatments that we've got are at best useful for holding the infection, but actually generally I think they're not very good at all.
Yeah. Now, a question to both of you. What about gene therapy? That's also what Jimmy Goy asked.
Yeah, so, gene therapy, of course, I think is in the mix with transplant. Essentially, you're talking about replacing a cellular defect. Gene therapy has come an awful long way since it started back in the mid-1990s. And for some diseases, it's definitely there. There are some issues with it, I think, for all of the diseases. I don't know how much correction you would need in XLA, and the answer is probably not a lot, because a bit like SCID, as long as you've got some B cell production, you would probably have reasonable protection from the problems we're talking about. The BTK gene, I think, is pretty big, so one can imagine that trying to get it in would have some issues. And I'm not sure what sort of regulatory elements you would need. But sure, if we could get gene therapy to work for XLA, absolutely. But I don't know what you think, Marcia.
Yeah.
No, I totally agree. I think that probably one of the next steps would be gene therapy for XLA, counting out the risks of a conventional stem cell therapy with graft-versus-host disease. And then you would have actually, with lower risks and more gain, it would probably be a very interesting option. I think it's the next step, especially if you're, if we all followed the presentation of Andy, we see that probably current treatment is maybe not sufficient.
Yeah. Okay. Now, Maartje, and thank you very much for having this interesting discussion, and thank you all for participating. But before leaving, we have still the same question for you. So I would like to ask Margarita to open the question again. So after hearing the presentations, and we would like to poll your opinion again to see whether your opinion has been changed. And now we have two questions, because one is about the screening itself, and then we have a second question with a bit more detailed question. So the first question is again, KREC newborn screening for XLA, yes, no, maybe, I'm not sure, no opinion. So 67%, that's a bit more that say yes. Also, I think a bit more or about the same. Maybe I'm not sure. So it's 1/3. So there has been some change, but I think you're not really change your opinion after the discussions, but still I'm not sure is 1/3. So we go to the second question. So that's a bit more, but if you have say yes, how would you do it? KREC as standalone assay, KREC with cellular second tier, so like Maartje indicate with the epigenetic qPCR, KREC with genetics as second tier, so with the sequencing, or genetics as first tier, or no opinion. So 6% KREC as standalone, the majority votes for KREC with genetics as second tier, and followed by KREC with the cellular second tier, and 7% for as first tier. That's the same as the KREC as standalone. Now, thank you very much also for participating. I would like to thank ESID and especially Siobhan Burns for organizing this webinar. Of course, I would like to thank Andy Kennery and Maartje Blom for their presentations and the interesting discussions. Thank you much, and I hope seeing you again with the next ESID webinar.
Thank you.